All right, let's get started again. 30 minutes on making the diagnosis of physical pulmonary embolism. We're going to expand the topic a little bit from what's listed as the topic in the book, because we have the time. Ricky, a little feedback. You can turn it down a little bit. One of the things I think is interesting in this is how this evolution has taken place. There's very few things in medicine, I think, where the diagnostic approach has changed as radically as is pulmonary embolism. And from a historical point of view, I think it's interesting to point out what used to happen in the old days. In the old days, they would basically say, you got a swollen leg, you're having a pleuritic chest pain, you have S1Q3T3, you have tachycardia, you probably have a pulmonary embolism, and they would begin to treat you with dangerous drugs, heparin and Coumadin, and you'd be on the Coumadin for, it was variable, but relatively long period of time. And we get to see all of the Coumadin issues in the ER of people wound up bleeding, et cetera, et cetera. One doctor did something very radical in the 70s. He said, wait, before we give these people the medicines, let's really do something that is pretty radical. Let's do a pulmonary angiogram on them to see whether they in fact do have a pulmonary embolism. And when they did that, only 25% of the people who would have been clinically diagnosed and clinically treated ultimately were determined to have a pulmonary embolism. It was like the light bulb went on and said, geez, the majority of the people that we're diagnosing with this and putting on these dangerous medicines do not have this disease. We were overdiagnosing the young, smoking, birth control pill-taking younger people and underdiagnosing the older people, but we were clearly overdiagnosing a lot of people because we did not have a really good test, and people were afraid to expose people to pulmonary angiography thinking the risks were pretty great. But the fact is, the risks of Coumadin and making the diagnosis wrong was probably even greater. And there are a couple of papers in here that say we're still having some issues making the diagnosis. There's these autopsy papers, like 1 and 2 are both papers that say, we're still missing people, particularly in the hospital setting. So what we're going to do is go through what's the standard these days, what can be defended in terms of this process. The first step is, and that nobody absolutely disagrees with the first step. The first step is that you have to somehow get a sense of, does this person have a low, intermediate, or high risk of having a pulmonary embolism based on clinical issues. Your judgment, using somebody's criteria, that kind of thing, because the whole algorithm requires that you know where they are, low, intermediate, or high probability. Because if you're a high probability, you're going to do some things that you would not do if you're low probability. So that's the driver, number one. How good is physician judgment in determining whether this person is low, intermediate, or high? You want to see a really discouraging paper, take a look at number 3. This paper looked at 92 clinicians, emergency physicians, internists, PAs, they were all in the emergency department. They gave them 4 clinical vignettes. They all read the same 4 clinical vignettes. One of them was a chest pain vignette, another of them was a potential PE vignette, DVT, and UTI. And then they asked the doctors, based on this story that you've just read, what do you think the likelihood is of this person having an MI, PE, DVT, or UTI? And you would think that, well, the most doctors would kind of cluster, and they tended to do it, but there were some doctors, as an example, on the MI scenario, the doctor would say, there's a 3% chance this person has an MI. The other doctor, said 98% chance this person has an MI. They both read the same data. And the variability was huge. PE, 5%, 80%. DVT, 30%, 100%. Even something as simple as a UTI, some doctors said, I think it's a 10% chance, another doctor said a 100% chance. They read the same identical facts. So it shows you that although your judgment is pristine in this matter, I'm not so sure about your colleague next door to you in terms of their ability to assess reasonably. And so this is scary information. It basically says any one doctor's opinion is a problem. Collectively, doctors do pretty well, but in any one case, doctor's judgment is an issue. So number 4 demonstrates that collectively, doctors do really pretty well. This is a cool paper. One of the things that you find in these papers is the difference between the American papers and the European papers. When you look at the European papers on PE, when they do the gold standard test, whether that be a CT angiogram or something like that, people are still in Europe about 25% of the people, when they do the test for PE, turn out to have a PE. Look what happens in the United States. Robbins, in the 70s when he did the study, yes, 25% of the people they did pulmonary angiogram had a PE. In Europe, that number is still holding the case. However, look what's happening in the United States. We're evaluating more and more and more people as having suspected PE because we kind of got the message we're maybe missing this diagnosis. So the threshold for us to evaluate somebody for making that diagnosis has gone down substantially. And now in the US studies, it is typical or common to see the yield being much lower. So in this paper, just as for fun, number 4, the yield here was 6%. 6% of all the people they evaluated had a PE, not the 25% that we've seen in the past. And I'll show you other papers just to make that point that the number is a lot lower than it used to be. So this is about giving doctors collectively the ability to make a judgment about whether a person has a PE, comparing it with the Wells criteria or the Charlotte criteria. There's a bunch of different criteria. Wells is obviously the most well-known. So they took 142 doctors, and the doctors collectively concluded that 69% of these people were in low risk. The Wells criteria said 73% of them were low risk, and the Charlotte criteria said 88% of them were low risk. When they did the evaluations for these PEs, how did the doctors do? The doctors did the best. In the patients who were considered low risk by the doctors, only 2.5% of them had a PE, 1 in 40. The Wells criteria, 3%. 1 in 33 had a pulmonary embolism, and the Charlotte criteria, 1 in 25 had a pulmonary embolism. So the doctors actually were quite good, but you're not going to be able to get 142 doctors to evaluate your case and say, what do you think? So that's the problem. That's the problem. It's going to be you. And it's not likely that you will want some help in that regard. And one of the things that you'll probably gravitate to, hopefully, is some kind of validated risk stratifier, because our first paper showed any individual doctor could be pretty far off the mark, and you don't necessarily know where you stand in this. The combination of physician judgment and using these criteria like the Wells criteria is probably the best thing. That's pointed out in number 5, and we really don't want to blindly follow these rules. I'll show you some examples where doctors overread the rules, overwrote them, and said, you know, I know that this person's workup is negative, but I really, 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 really believe that they have a PE. And in some of those cases, when they did the studies, they basically proved that they were right. The question next is how reliable. Well, let me just step aside. We start going down this path of does this person have a PE? Once you start down the path, it's very difficult you can't go halfway down the path. So it's a kind of go, no-go decision kind of thing. And we kind of think about, well, is there data to support going down this path? The history, the physical, we know about EKG, we're looking for sinus tachycardia, S1Q3, T3. This paper number 6 says, not so fast, doctor. This looked at 49 patients who had bona fide pulmonary emboli. No EKG changes were identified that were useful in distinguishing patients with and without PE. None, 0. There was a study of there's 5 papers in the world literature that were summarized in the Emergency Medicine Journal, which is a British journal, came out in October of 2005. World literature, 5 papers, said many methodological issues, which may be watered down their conclusion. Yeah, they said several EKG abnormalities were relatively more frequent in PEs, but those abnormalities were infrequent, they had low sensitivity and low specificity. So even though we like to believe you're supposed to have sinus tachycardia, that would be a pretty good-sized PE to generate a sinus tachycardia. And we're not really worried about the big ones. We're worried about the small ones that will miss, send home, and then a month later they have the locomotive that comes down their pulmonary vasculature and takes them out. We're not worried about so much the one that's there today, it's the one we're concerned about, because if a person's got enough hemodynamic compromise that now they've got sinus tachycardia, clear chest x-ray kind of thing, you're not talking about a small pulmonary embolism here. How good are these stratification algorithms? The Canadian rules, the Wells rules, have a little Achilles heel. What is the Achilles heel of the Wells rules? And the Wells rules are on the next page. And the Achilles heel of the Wells rules is the second item there: an alternative diagnosis is less likely than PE. An alternative diagnosis is less likely than a PE in this patient, which requires your subjective judgment. And we don't want any subjective judgment here. We want black and white facts that everybody can ascertain. So this is a problem. So a lot of these other criteria are trying to use things that are objective, measurable, no disagreement about them. Yes, you did have surgery within X days, those kinds of things. However, despite the fact that this very soft criteria is in there and counts disproportionately in the point system for deciding low, intermediate, or high probability, doctors seem to be able to do pretty well with this. And there you go. If you were to take a look, now if you have less than 2 points, you're considered to be low probability. 40% of people are considered low probability, and look at how many have an embolism. 3.6%. If you go back to the paper where they compared it with doctors, that's just about what they got in the Wells criteria in that paper. Doctors were a little bit better. After you've stratified these people by using this, probably you ought to use the Wells criteria because your judgment may be challenged. Which means that the Wells criteria got to be around someplace on your PDA or someplace where you can get to it pretty quickly to stratify, because stratification is by far the single most important thing that you do at the beginning. What do you do after that? The British Thoracic Society came out with some guidelines. Their guidelines are the most recent. I've looked at them carefully, and I think that they're very, very defendable based on the literature. We have, those of you who are subscribers know that we have a disproportionate number of papers on this topic in our database, and we're kind of trying to swear off these papers because we got a little addiction to them. But the fact is, British Thoracic Society came up with what I believe to be literature-supportable approach. And what do they say? First of all, you stratify. If a person has a high clinical probability of having a pulmonary embolism, you do not order a D-dimer in any of those cases because it doesn't matter what the results are if they have a high clinical probability. Now, if you go back up to the chart, according to the Wells criteria, only 7-10% of people would be considered to be high probability of having a pulmonary embolism, and that the majority of people are in this middle category with a substantial subset, 40-35% considered to be low criteria. So if you have somebody high, basically British folks say, based on the literature, which I really believe is true, don't bother doing a D-dimer. They have to go to an imaging study. If you have a low probability, you believe it's low, the Wells believes it's low, everybody believes it's low, you do an ELISA D-dimer, and if the ELISA D-dimer is negative, the workup for pulmonary embolism is over. The workup is over. Now, does anybody do that in this room? The literature on this is compelling. It is compelling. And we'll go through some of the reasons that it is in a second. Now, the British Thoracic Society also says that if you have an intermediate probability for having a pulmonary embolism clinically, your assessment, the Wells assessment, whatever, it says intermediate, and the ELISA D-dimer is negative, the patient's workup is over. They go home. A lot of people would feel a little uncomfortable with that. And I could certainly understand that. But on the low probability, that's what they say to do. So technically speaking, you would not even have to do a chest x-ray in a person who is being evaluated for a pulmonary embolism. You don't, basically, they get negative D-dimer. And they're talking about ELISA D-dimers. ELISA D-dimers, the one that is written about the most is the Venous D-dimer. And then there's the latex D-dimers, a little less accurate kind of thing. And the British say, if you only have a latex agglutination D-dimer, that you cannot send people home who are in the intermediate risk class. You can only send home the paper in the low risk class if you're using any latex. However, any hospital worth its salt is going to have, because of this diagnosis being so important, they're going to have some kind of ELISA D-dimer. So that's what they say to do. We don't really feel comfortable with that because we haven't done that, but you can see a small number of your colleagues, and the literature is really strong on that, that's all you need to do. So what you might do something else, like maybe you could do let's scan their legs. I'll show you later that basically papers show that between 60 and 80% of people who have PEs will have a clot in their pelvis or in their legs, and that this is one continuum of a diagnosis. VTE, venous thromboembolic disorder, is the more catch-all for this thing. So you could scan their legs. Even if their legs are perfectly normal, they don't have anything swollen legs. If you find a clot, an ultrasound is not as good as finding clots in people who have asymptomatic legs. It's much better if you have a swollen symptomatic leg in determining whether you have a clot. But even if you have normal legs and you scan the legs and you find a clot, the diagnosis of pulmonary embolism is made, because you're evaluating people who've got chest symptoms. You found something in the legs. This relationship is so clear-cut that you have made it clear that this is the diagnosis. Now, you'll probably still want to go on an imaging, but the diagnosis is PE in those cases. So that's what the Brits say. Number seven is a review of 78 prospective studies. 78 prospective. A lot of work done by Paul Stein, who's one of the gurus of pulmonary embolism. Look at the relatively high frequency of making the diagnosis, 25%, atypical for the US. And he points out that the D-dimer is only helpful if it is negative, and clinical risk stratification is not high probability. So he's basically reinforcing exactly what the British said. It's a Canadian doctor kind of thing. So it's only good if it's negative. But some of us, if we have a low threshold, set out, okay, I'm going to send out a D-dimer, just to check it out kind of thing. What happens if that thing comes back positive? If that thing comes back positive, you have committed yourself to go down the path further. You have no choice now. So the implication is that you have considered the diagnosis of pulmonary embolism. You have done some kind of risk stratification, which you probably may or may not have done in terms of any formally. But if a nurse sends off a D-dimer without you taking care, without your assessment of that patient, it makes it very problematic because you're only looking for negatives in these cases. So the fact of the matter is that you wind up having to do the next step of the evaluation. This guy is the guru. A positive ELISA is of very little clinical value. It doesn't mean, most of them are false positives for the diagnosis of pulmonary embolism by far. Number 8 makes a couple of important points. This is a large study, 1,200 patients in the United States. The miss rate for a low-risk patient with a negative D-dimer was 1 in 1,000. So then, what is the gold standard? The gold standard for pulmonary embolism, you have two choices. You can do a pulmonary angiogram for the gold standard, but certainly that's going to miss 1 or 2%. Or you have another gold standard, which more and more people are incorporating, and one of the biggest critics of that standard is just walked into the room, is the idea of what happens to you if we don't treat you and we just follow you up for 3 months. And do you develop any pulmonary emboli during that period of time? And if you do, then this workup that we did today, which appeared to be negative, really probably wasn't, because look what happened. You got another clear-cut pulmonary embolism down the road. They are using this as a pragmatic gold standard now, because you can't be doing pulmonary angiograms on all these papers. And frankly, we don't care if you have a pulmonary embolism that is small, that results in no consequences. If we can get away without treating you and nothing comes of it, great. That's really a pragmatic gold standard. So more and more people are doing that, and that's what they did in this case. Now, Jerry's objection to all of these papers is that during these 3 months period of time, some people will die, or some, and will they all have autopsies, and they died, and some of them had cancer, and they died over the 3-month period. What did the cancer patients die of? Well, we're not necessarily sure. So Jerry's position, which I'm going to articulate for him, is we really don't know whether these patients have or had not had pulmonary embolisms, despite the fact that paper after paper after paper says, we don't really think they did. Jerry's point of view is, you don't know that. You don't know that. How am I doing, Jerry?
Pretty close. Just what the doctor didn't write down on the autopsy form, on the death certificate, pulmonary embolism, wrote down cancer instead. Just sort of guessing that maybe they were related.
So that's kind of the criticism. But the fact of the matter is, it's a very pragmatic and useful approach if you can deal with Jerry's objection. So And this next paper here brings out the point, number 8 also brings out the point that if you believe that this person has a pulmonary embolism, despite the fact that the D dimer is negative, and the Wells criteria for some reason turns out that they're intermediate probability, if you believe strongly that that's the case, you should run with your beliefs. Because in this study of a couple, 1,200 patients, 2 patients were imaged despite a negative D dimer and low clinical risk using the Wells criteria, and both are positive. So basically, don't give up on your judgment in these cases. All right, the next question. Assuming a patient has a high clinical probability for PE, or the D dimer is positive and the patient has a low or intermediate risk, what's the next step? We used to do VQ scans. That used to be the standard imaging study. VQ scans, in the vast majority of patients who are not young, will be indeterminate, which means it's not like the study was even done. It means that we don't know. It means we don't know, indeterminate, the majority of the people. If a VQ scan said normal, the vast majority of people with normal VQ scans will not have a pulmonary embolism. It's not 100%, but no radiologist will say a VQ scan is normal. It's a reportable case for them. So we've given them the opportunity to say normal, near normal, normal, near normal. They feel better when they're allowed that. But when they say normal, near normal, now you're up to like 3% of them are going to have a pulmonary embolism, a number which is not something that is of no consequence. So VQ scans have largely gone by the board. Papers 9 through 11 make the strong case that I initiated before about why you should do leg studies. They don't involve any radiation. If you find the fact that there's a clot, if you find the clot, there is a clot. Specificity is high. Sensitivity is variable depending on whether you have symptoms or not. So that would be a reasonable thing to do to help make the case that this person has a pulmonary embolism or does not. But it's often harder to get an ultrasound in the hospital than it is to get a CT, especially at night, kind of thing. So this only works between the hours of 10 and 2 during the day. This idea of let's get an ultrasound as part of the routine workup of a suspected pulmonary embolism case. Number 9 brings up another point. What to do? D dimer is positive. The patient has a high clinical probability for PE. The leg ultrasound is negative, and the chest CT is negative. There's going to be a small number of patients, 2-3%, who need to have a pulmonary angiogram to make the diagnosis. The radiologists or the cardiologists have to be willing to do pulmonary angiogram in a small number of cases. 11 points out the tight relationship between clots in the legs and clots in the lungs. In this study of people, 213 of them had PEs demonstrated. They did venograms in all of them. Asymptomatic, symptomatic, didn't matter. Everybody got a venogram who had a pulmonary embolism. 82% of the patients had venogram documented DVTs. 82% of people with PEs had DVTs in this relatively large study. 3/4 of those DVTs were proximal. 40% of those venograms had positive leg symptoms. So 60% of the people who had a positive venogram had no leg symptoms. The majority of people had no leg symptoms who had a positive venogram in the setting of a PE. So it shows to go you. It doesn't matter whether your leg is swollen or not. It's highly likely that you've got a clot in your legs, and if you can find it, you make the diagnosis. So you've decided to do a lung CT with IV contrast. How accurate is a lung CT? Well, it's clearly the more peripheral this clot is, the more difficult it's going to be to see it. We're not going to have a difficult time seeing this big saddle embolism kind of thing, which is blocking all the blood flow into the lungs. The neck veins are distended. The right atrium is huge. You know, those kinds of things. The person's in shock. That's not going to be the issue. It's all of these little guys way out there. And the little guys, are they just as capable of generating big subsequent emboli? Or do little guys beget little guys in the future? So this is the question. And the question is how good are the CT scans? If you read paper number 12, it is Frightening. It is frightening. But this is old. And see, the value of CTs and the accuracy of CTs is a moving target. It's a moving target. So this is published in the year 2000. Look at how many people had PEs in this study, 39%. In the US, 6%. And when you look at sensitivity and specificity, it was abysmal. It was abysmal. However, we never will know this because it's moving all the time. It's got to be better than this. The generally reported miss rate of pulmonary angiography, not CT, shooting dye into the thing by the radiologist doing an angiogram, is in the neighborhood of 1 or 2%. I will show you what the numbers are in terms of the miss rate in a bit, with some other data that is more recent. So papers 13 to 19, a series of papers in order publications, all supportive of the clinical accuracy of lung CTs with contrast from a pragmatic approach. The pragmatic approach is, we don't really care if you have, are you almost, is it your time? Okay, we don't care whether you really have it. We want to know what's going to happen to you. And they basically say not much happens to you when you read the CT as negative. But papers 20 and 21 are the ones that I think are most important. This says, and some of your hospitals I'm sure are doing this, while we're going to do the chest CT, we're going to scan the legs as well. We're going to shoot the dye in, scan the lungs, and scan the legs and pelvis. And how many of you do this routinely now? Nobody in the room does this routinely? This is becoming more and more and more because you have to decide to do this when the test is ordered. So they scan legs and lungs at the same time. Well, we're going to talk exactly about that in a second. Number 20 and 21 both talk about how many people are identified who have a negative chest CT and a positive CT of the legs, identifying clots. Negative chest CT, positive venogram, which would support the idea of doing this. These are large studies. Cornell, 1,600 patients had both legs and lungs done at the same time. And the lung CTs are positive in 15%, which is kind of the number we're getting down to. How many people had legs positive, lungs negative, who are being evaluated? There was 48 patients who were determined to have positive leg studies and negative lung studies. What did this do? This increased the yield of pulmonary embolism by 16%. What it in essence said is the CTs are wrong 16% of the time if you believe that these studies are correct and that when you're evaluating for somebody for the lungs, if they got in the legs, they've got it. So it was 16% in paper number 20, and paper number 21, 800 cases. The yield improved by 17% when you did the lungs and legs. The problem with that is you double the radiation. And whether it ought to be done routinely, I don't think so. Because number 22 talks about the radiation doses here. When a woman gets a CT of her chest, she gets the equivalent of 10 to 25 mammograms. She gets 7 times the amount of radiation recommended by the American College of Radiology for a mammogram. And you get all of this opportunity to create solid tumors over time. You'll never be blamed for it, because it's going to take 10, 15, or 20 years for those tumors to develop. The lifelong risk of death due to radiation from a chest CT is 1 in 4,000. Now, people can challenge those numbers and say, well, it's based on Hiroshima, this, that, and the other thing. We'll never know exactly. But people think it's in the neighborhood of 1 to 4,000. When you do the lungs and legs, look what happens to the testicular and ovarian radiation. Goes through the roof, 470-fold increase for the ovaries and testicles, were 2,200-fold increase in radiation, and 1 in 4,000 for the chest, 1 in 4,000 for the legs and abdomen, lower abdomen. So it's now 1 in 2,000. 1 in 2,000 people are believed to die from getting this study. 1 in 2,000. It won't be on your watch. So I would suggest that this is a reasonable thing to do if the person is 75 years old. Because radiation doesn't matter to a 75-year-old. Light them up. But it certainly does matter to a 25 or 30-year-old where we traditionally overdiagnose these cases. So I think in those cases, we have to be much more careful about irradiating these people, would not do it routinely, would ultimately ultrasound all of their legs as part of their evaluation. But I think that there are substantial issues to consider if you want to limit long-term risks in these patients. Not everybody should have this. And I'm really surprised at the very small number, because I've done these courses a bunch of times this year, and this is the smallest number I've seen. There are many places where this is routine. We do legs and chest simultaneously.